Hi, Dr. Averhart. Thank you so much for joining us on MD Newsline Podcast. Can you please introduce yourself to our audience?
Yes, of course. My name is Dr. Wanda Averhart. I'm a general pediatrician and obesity medicine specialist. I've been practicing for about 8 years. I do a variety of outpatient pediatrics and obesity treatments. Um, yeah.
So, on the topic of obesity, specifically childhood obesity, what is the impact of that across different populations?
Wow, that's a very broad question. When you say different populations, I'm assuming you're talking about different
Hmm.
ethnicities. And of course, with children, you're talking about different ages from newborn to toddler to childhood to adolescent. Huge impact. Okay. 1 in 5 children are obese. And that means that their weight is higher than the 95th percentile for all kids their age. And there's a lot of contributing factors for that. It's environmental factors, it's social factors, it's genetic factors. It's a very large burden in today's society.
Wow. And I want to hone in specifically on infant obesity because I feel like we don't talk about that a lot. I hear a lot about childhood obesity, but not a ton about actual infant obesity. It didn't even occur to me that that was a thing. But I'm wondering, how do different infant feeding practices, such as exclusive breastfeeding, formula feeding, and the timing of complementary foods, contribute to childhood obesity risks in various populations?
So you're absolutely right when you say infant obesity isn't really a thing because it's not really a thing because we don't look at BMI percentiles or anything in newborns or in babies. We just look at how they compare to other kids. And so newborns can be large when they come out, and we call it large for gestational age. A lot of the factors that contribute to that include genetics, mom's health when she's going through pregnancy, but also feeding patterns. I'll give you a good example. All right. I was in residency and I was doing newborn rounds where I go from room to room to see babies that had been born within the first 24 hours. And I go into a mom's room and I see her breakfast plate and she got something in her hand and she was pushing it in the baby's mouth. Mind you, this baby has only been born less than 24 hours. And I say, Mom, what are you feeding the baby? What's on your plate? And she said, yeah, she was feeding the baby oatmeal. And I was like, well, that's not best practice. That's not what we want to do for your baby. So when infants are being born and they're being given food other than breast milk or formula, that increases their risk of obesity as they age. So, yes.
And is there a such thing as an infant that is too big in comparison? Does that impact their health in any way as far as their size when they are born?
Yes. So we call infants that are born a lot bigger than normal large for gestational age. So the size of a newborn is determined by how long they stay in the mom's womb. So if you take a baby out at 23 weeks versus 40 weeks, you're obviously going to get a larger baby. But even if you take a baby out at 40 weeks and they're 11 pounds, that is way beyond what we'd expect a newborn to be. So that's large for gestational age. As far as uh, oh, back to the question you asked. What was the question you asked?
Impact on health.
Impact on health. So for the child's health, it depends on why they're large for gestational age, right? The most common reason we have children that are large for gestational age is moms that have diabetes. And so there are lots of reasons why moms have diabetes. It could be that she has an insulin issue and it's genetic and it's not related to her eating patterns. Or it could be that the mom has eating patterns that are causing her to have obesity. And as a result, when that baby comes out, they tend to have sugar problems. They're jittery. We have to monitor their levels. And so that alone impacts the child's behavior and growth when they first come out if they can't control their sugar or they have bad sugar levels.
And on the topic of eating patterns and feeding choices, like you mentioned earlier, how do cultural traditions and parental beliefs shape feeding choices in infancy?
Yeah, that is a really good question. So, if you look at the American Academy of Pediatrics and they talk about how to introduce solids in feeding, the recommendation is to continue formula or breast milk for at least the first year of life, at least. The end date is up to you, especially when it's breastfeeding, but usually formula until 1 year of life. Now, when you start to introduce solid foods, there isn't a hard, steadfast rule that the American Academy of Pediatrics adheres to. It is absolutely based on your cultural practices. So, in some cultures, they give their babies mangoes, pureed mangoes as the first food. In some cultures, like here in the US, we'll usually do like a rice cereal or a wheat cereal as one of the first foods because it's iron fortified. That really plays a big factor in how you introduce those solid foods as the baby's aging.
Now, have recent trends like baby led weaning or responsive feeding shown impact on mitigating or exacerbating disparities in obesity?
I don't know if I would say that baby let weaning or other, I guess, methods of feeding mitigate disparities, but it may show disparities that exist or that already exist. I do find that parents that have a little bit more education, resources, are able to kind of adhere to different patterns in feeding their child, and that alone tends to give them a better outcome because if you're closely monitoring what your child is eating, you're most likely trying to give them fruits or vegetables or stage one foods and then move to stage three and stage two and stage three. And so that alone just kind of makes them have a better outcome. The other thing is, parents that don't tend to know about those patterns tend to be a little more lax in how they introduce foods. And so those may be the parents that introduce the oatmeal at birth, right? Or they're giving them the really salty, buttery mashed potatoes as their first food.
And those babies with kind of some of those eating habits are more likely to have a higher BMI later
Later
on
in
in
life.
childhood.
Yep.
Is there evidence linking early feeding interventions to closing that gap in BMI in different
Oh,
social, economic
okay.
groups and even ethnic groups?
Um, yes, so there is evidence that there are feeding habits or feeding patterns you can introduce that will close the gap in obesity throughout the ethnicities. One of them is breastfeeding. And so, of course, breastfeeding allows a child to self regulate. They're hungry, they go to the breast. When they're done, they stop feeding. Another one is the introduction of solid foods. So, within that first year of life, you start to introduce foods, not just formula, not just breast milk. The earlier that introduction, the more likely your child is to be obese. So I have parents that say, "Oh, my child's 4 months and or even 3 months, and they want the chicken that I'm eating." So I give them a little bit of chicken. And yeah, it's the fried chicken, and they like it. That child is more likely to be obese than the 6 month old that starts feeding, but they're starting with peas or carrots, right? And so, yes, those are some of the things.
And is that likelihood because of the likelihood that they will continue in that pattern of eating those types of food, or does it do something to the body to introduce food at that age?
Yes, and yes. So, number one, um, a child's risk of obesity is highly influenced by their environment and what they see at home. Even a child that is genetically, biologically going to be thin, if you put them in a household where there's nothing but fried food and no vegetables, that child is gonna most likely end up overweight or obese. So, yes, it does have an impact environmentally, but also biologically. So, remember, I talked about when children are first born and they're at the breast and they're deciding if they're satiated or not. And this is something that they have to figure out in their brain, in their stomach, and the hormones that regulate that. If you're in a household where you're not able to self regulate, now your hormones have changed and you ignore ignore the sign that you're full. I know they'll tell adults all the time, if you wait 20 minutes, now your brain has had time to produce hormones and let your brain know that you are full. Same way with kids, right? Same way.
And I know that the pandemic impacted a lot of people in different ways. Are pediatricians seeing changes in feeding practices post pandemic, and what implications do these have for obesity risk?
Ooh, feeding patterns post pandemic. This probably has nothing to do with obesity and more nutrition, but I saw a lot of kids switching over to goat milk. Yeah, it wasn't a thing before the pandemic, and I have to say it may have been due to like formula shortages, but that's more of a nutritional risk when you're missing vitamins and things like that. As far as obesity and eating post pandemic, I haven't seen any big changes.
Mm. And I know we have these ideal feeding recommendations, but everybody can't necessarily follow them based on things like food deserts, access, or even just levels of education. Are there unique barriers to following these ideal recommendations in low income versus high income households?
Oh, yes. So the standard feeding recommendations, depending on the age of the child, I've really been focusing on infants under the age of 1, but even children. The idea is you need to eat 5 servings of fruits and vegetables a day. That is the recommendation. If you're living in a food desert where your closest grocery store or closest place to get food is like a corner store, then you may not have access to that number of fruits and vegetables. And so, of course, children that eat less than that recommended 5 servings tend to have obesity and overweight. So, yes, your environment does play a factor into your ability to um, achieve a healthy weight.
What advice would you give families who are dealing with food insecurity but want to make sure that their kids and infants get that optimal nutrition and learn those good eating habits?
Okay. So the first thing I always talk about is making sure you get connected with services. So although you live in a food desert, although you live in a place where you may not have optimal nutrition, you can gather that by participating in WIC. They can get you breastfeeding support, formula, make sure that you have adequate resources to get the fruits and vegetables. And then the other thing I tell parents is that it's not only about nutrition when we talk about weight and maintaining a healthy weight. Think of the numbers 95210. Those are 5 ways that parents can help kids not only have a healthy weight, but get to a healthy weight. 9 represents sleep. Sleep is very important. 9 hours of sleep at night. 5 servings of fruits or vegetables per day. All right. 2, less than 2 hours of screen time. And that's so that your child is not sedentary. 1 hour of exercise a day. That is the daily recommendation for all kids. 0 is probably the hardest one for kids to really adhere to. 0 sugary beverages. So that means even the no sugar added juice, which is allowable on WIC, right? But sugary beverages, so juice, pop, even no sugar, but taste like sugar type of beverages. Because what we're doing when kids age and as they're growing is that sugar craving, right? If the first food you introduce to your 6 month old is like a sugary, sour candy or something, now they're growing up and their taste buds are just wanting sugar. And it's going to be even harder for them to resist it as they get older. So, sugar is a big one.
Interesting. We talk a lot about the state of the mother during pregnancy and how that might impact child health. And I'm so curious, could you clarify the mechanisms by which maternal stress during pregnancy and maybe postpartum can influence obesity risk?
Mm. So that's a really good question. Stress in general is going to impact the child uh, due to where the stress is coming from. Is that stress because of food insecurity? Is that stress because I don't have enough money to make sure that I'm taking care of the child? Is that stress because I have to pay 375 for lunch and I haven't completed the lunch application? So stress alone can make it very difficult for parents. Repeat the question for me.
Um, During pregnancy and postpartum.
Okay, how does stress impact the child?
Yeah,
During stre-
there's a follow up question that might be easier to tackle. How does stress biologically shape appetite regulation and metabolism in infants?
Stress. Okay. So the way that stress impacts infants and children is through the cortisol pathway, right? So if you're highly stressed, and this This works with children, adults, infants. If you're highly stressed, your cortisol levels are going to be high. Same thing if you're not sleeping. That cortisol drives you to want to eat. It gives you cravings for sugar. And if you are able to resist it, hey, but most people can't. And therefore, you're eating. That in turn deregulates you, and then it becomes this vicious cycle. So it's through the lens of cortisol.
And with cortisol in mind, or even any other hormones, is there a relationship between maternal mental health disorders such as depression and anxiety and childhood obesity, even
Mhm.
whether it's biological or mediated through feeding behavior patterns?
Yeah. Um, so, I mean, of course, usually the way the biology of maternal mental health transitions to children is through genetics, right? And so if I have a genetic condition that makes me more likely to be depressed, and then that child has the genetic condition, they're also likely to be depressed or have other issues. But then it's also just how can a depressed mom who's not treated really, really take care of a child very well, right? And so sometimes those children are fending for themselves. They're walking down to the corner store and getting whatever they can to have a snack after lunch or after school. And as a result, it may not be the healthiest. And so that in turn can also increase the risk of obesity.
And what screening protocols or support systems tend to work best for at-risk families?
So that's a good question. What screening protocols exist for at risk families for mental health disorders, for obesity?
Both. Let me clarify. Yeah, for either, let's say for mental health and for, let's just go with mental health.
Okay.
Yeah,
So the protocols we have in place.
yeah.
Okay.
So, what screening protocols or support systems work best for at-risk families that are dealing with mental health disorders, like what we mentioned with the mothers?
So the screening protocols we have in place, at least with the American Academy of Pediatrics, who is the authority that kind of sets all the protocol and policies for pediatricians, is we have a depression screening. And so the recommendation is to screen every parent that brings a child in before the age of 9 months for depression and then act on it if depression is present. So that right there kind of gives you a clue. And then anytime that you suspect, I've had moms come in and I'm just like, you said you weren't depressed, but I've been talking to you for about 10 minutes and I feel like you're a little sad. Can we talk a little bit more about that? So that's the number one. Number two, other protocols we have in place to identify um, what is it, mental health issues
Hmm.
or
Hmm.
moms.
The
Oh,
support systems.
support system. So that was for our tiny baby. So um, for our older kids, when they come in for visits, we have what's called a ACE, Adverse Childhood Events Screener Questionnaire, where we ask parents about different things that have gone on, food insecurity, has anybody touched you in the wrong way, those type of things to kind of identify other uh, adverse events that we can help with.
How does a child's genetics impact how susceptible they are to the adverse effects of maternal obesity before they're even born?
So that's a really good question. Let's say, for instance, a mother has twins and she suffers chronic obesity, right? The twins are fraternal, meaning they don't have the same exact genetics. But one twin is what we would say is a normal twin, doesn't have any genetic issues going on. And maybe the other twin has a condition that means they're just going to be small, like they're just tiny. And so mom has maternal obesity and maybe she has preeclampsia. Maybe she has high blood pressure. What that means is her placenta that's carrying the child may not get enough blood flow through it. And the biggest effect of that is the child doesn't get enough blood flow or nutrients as they're growing. So if you have the typical developing twin that's maybe not getting as much blood flow, when they come out, maybe they're just a tiny bit smaller, right? But then you get the twin that is genetically predisposed to be smaller, not get enough blood supply. When they come out, they may be in the NICU. Their brain may not be developing as well. They may have a hard time gaining weight. And we know that newborns that have a hard time gaining weight end up becoming the ones that have a hard time getting the weight off.
How common is childhood obesity showing up with comorbidities like hypertension, fatty liver, metabolic syndrome? How related are those two things?
So that's a wonderful question. So what you're asking is, how prevalent are the comorbidities of obesity in children? Over the years, it have become more prevalent. I've seen a lot of kids with high cholesterol or fatty liver disease. I actually had a kindergartner with extremely high cholesterol that wasn't genetic because it was a kindergartner and it was like a first grade, two kids, same family. They both had very high cholesterol when I first screened them. I gave the mom the whole spiel. We got to reduce the fat in the diet. We got to talk to nutritionists. One child was able to get it going down. The other child, it started creeping up. And I asked the mom, I said, so, what are we doing differently in one child versus the other? And the mom was just like, I can't control. I can't control what that child is eating, but I can control what the other child is eating. So as a result, it's starting to go down. So I had never seen that before, but it's increasing. We're seeing more children with high cholesterol. We're seeing more children with high blood pressure, pre-diabetes, or even diabetes, as well as fatty liver disease. So it's increasing because we're having a lot more incidence of obesity, and all the things that kind of create that.
And is the prevalence of these comorbidities similar among different ethnicities and socioeconomic statuses?
Of course not. So I think it just goes back to the idea of disparities. Childhood obesity is one of those that have a lot of factors that contribute to the development of it. And some of those are beyond the control of those that suffer from it, from food deserts to transportation to not having a healthy place to walk or exercise. There are a lot of factors that contribute to it. But no, in general, when we talk about disparities, people of Hispanic and Black backgrounds tend to suffer more with the condition than those that are white, as well as those that have lower socioeconomic status have a higher burden than those that have a higher socioeconomic status.
How does that impact practice in areas where there are lower socioeconomic status or ethnic groups that are more likely to face these types of comorbidities? How do the treatments required for those two things overlap?
So, again, this goes into the idea of what is a health disparity and what contributes to it. So, I work in an area that is of low socioeconomic status. There are lots of challenges and barriers. So, we put forth a very full throated effort to alleviate and accommodate some of those things that can contribute to it. So, do we need to get you access to the WIC? Or do we need to get you access to WIC? Yes. In higher socioeconomic status environments, clinics, they might not even think about WIC because they don't need any help with trying to get food. Do we have to make sure that you're connected with SNAP so you can get food coming in and actually have those benefits? So, trying to alleviate some of those barriers can be beneficial. And then recognizing the cultural differences. Um, in an African American community, I've seen lots of grandparents say, oh, that baby can eat solid foods at 3 months. And you're just like, let's bring granny in. Can you bring granny into the next appointment and we can have a conversation? And so just knowing what community you're working with and trying to alleviate those factors can be helpful.
And uh, what is your approach to patient communication and community-based interventions? We talked a little bit just now about bringing maybe the grandmother in. Are there any other programs or methods to communication that you found to be particularly effective in having those types of conversations?
So yes, there are lots of methods I've utilized in my practice when it comes to talking to children and parents about obesity. The first thing is just understanding the development stage of the child. That's one of the hardest things for pediatricians is we have to know what development stage the child is in. So if you're talking about a newborn or a toddler, they have no control over the foods that they eat. So the conversation should be targeted at the caregivers and the people that are preparing the foods. But if you're talking about a junior high kid, my conversation is with a junior high kid, and my typical thing is, "Are you eating Takis and tea, Arizona iced tea all the time?" And most of them are like, "Yeah, how did you know?" "Because I see y'all all the time." So then the conversation becomes a little bit more tailored to what the child can do differently to kinda mitigate those things. And then as an adult or as an 18-year-old, I can just be frank with you and say, "Hey, let's test and see. Do you have prediabetes? Do you have high cholesterol? Because I really need you to understand that your health is important." So it depends.
And then, as far as research goes, what gaps do you see in the current research regarding this topic, and what would you like to see the research field focus on more?
So when it comes to research and obesity, that is a very hot topic because especially in pediatrics, we are moving towards treatment. Since I started having an interest in obesity back when I was in med school. I started med school, I don't know, 2008, 2010, something like that. There wasn't any real treatment. It was always eat right, exercise, eat right, exercise. But now that we have new GLP medications on the market and we have new ones, we have like 6 or 7 more that are coming out in the next 3 years. We have a lot more that research that treatment is changing. And so now kids over the age of 12 can get semaglutide to treat their obesity. Of course, it's not a catch all and it doesn't treat all obesity because it is multifactorial. Like I said, you could have Beckwith-Wiedemann or Prader-Willi syndrome, which are genetic conditions that cause you to be obese that these medicines may not treat. But there's a lot coming down the pipeline, and with research, I see it being more focused towards treatment for obesity with GLP medications.
So, when it comes to populations that are most likely to be adversely impacted by obesity and the negative life outcomes that might come with that, such as populations of low socioeconomic status or ethnicities that are more likely to be negatively impacted. What do you hope to see in the future, and what would be your message for doctors as they serve these groups?
Great question. My word would be have a little compassion. I see a lot of parents and children that have struggled with obesity or overweight for many years, if not their whole life, and they don't feel like their provider, practitioner can truly understand it. They've been told, oh, you ate one too many sandwiches or you didn't exercise enough. And just understand that obesity is a chronic, relapsing condition. So even when you think you have it under control, you have to continue to work at it. And the same solution may not work on different people. So have a little compassion for those that suffer from overweight and obesity.
Well, this has been an amazing conversation. Thank you so much for joining us, Dr. Everhart, on MD Newsline podcast.
You're welcome. Thank you.